So again, I'm Dr. Jeanette Wade. I just want to say this project is a joint project at UNC Chapel Hill and North Carolina A&T. So I'll repeat the title. She felt like she didn't have an explanation, like I wasn't deserving of one. Sexual health care and gendered racism, stories from Black female undergraduates.
Black women in the United States experience unacceptably poor maternal health outcomes, including disproportionately high rates of death related to pregnancy or childbirth, as you can see on our table here. Too many women are dying in pregnancy and childbirth. Black women in the United States are more likely to die from pregnancy and childbirth than any other racial group. Black women are 3 to 4 times more likely to experience a preventable maternal death, as well as the pregnancy related spans income and educational levels. If you look at the other STIs like chlamydia and other sexual health outcomes, Black women also are disproportionately represented there. So part of our aim for this project is to understand what are the issues, what are the barriers, and how we can help improve gynecological health for Black women.
So one of the social determinants that we found when we did our study was patient-physician concordance. So in this study by Ryan Herberto in 2020, they explained the importance of physicians and patients sharing the same race and ethnicity. They found that this improves the time spent together, medical adherence, social decision-making, wait times for treatment, cholesterol screening, patient understanding of cancer risk, and patient perception of treatment decisions. This also obviously decreases physician bias to their patients. In another study in 2017 by Williams and Milan, they studied the cultural competency and its importance in communication between patients and doctors as it relates to care. So, Black patients that were nearing the end of their lives received much less empathy than their white counterparts from white physicians, despite receiving the same information. Despite receiving the same information, they also found that Black physicians are more likely to serve in underrepresented minority areas. So when Black physicians go back to their communities and back to their underrepresented minority areas, the patient physician concordance is then kind of equal because they're the same race, same ethnicity, and generally they have the same values. So when white physicians don't do the same, it becomes an issue. Furthermore, in Street, O'Malley, Cooper, and Hyatt study in 2008, they measured the post-visit patient ratings and patient-provider experiences, and they found that relationships were much stronger when patients felt connected across their personal beliefs, values, and their communication. And lastly, in Leviste and Carroll in the study in 2002, they surveyed and reported on patient satisfaction and other related variables such as patient centeredness. And they found that they had much improved outcomes in the race coordinates in the physician patient pairs. So the patients were much happier with their service, with their satisfaction when their races coincided.
Next, we looked at patient-provider non-concordance when it comes to age. In 2017, Hops and colleagues interviewed a sample of adolescents to understand their experience with healthcare providers. The young women are sampled reported experiencing judgment from the provider, a lack of trust and confidentiality, and a lack of providers' adaptation to patients' maturity level. Specifically, there's physicians asking 10-year-old patients about contraception. In 2009, DeVoe, Wallace, and Fire discussed how age is associated with patients' perceived communication with their healthcare provider. They found that the older the patient was, the more likely they were satisfied with their care, whereas younger people reported higher levels of dissatisfaction. And this was because the older that patients were, the more familiar they were with the healthcare system. Furthermore, they found that patients aged 18 to 64 were less likely to report their provider always listening to them, always showed respect for what they had to say, and always spent more time with them when they compared to patients 65 and older. In 2011, Peck found that age is relevant to both patient satisfaction and doctor-patient interaction suggesting the older the patient, the more likely they report satisfaction with their provider. And while there was some studies that were found, it's clear that Black women's experiences with age-related concerns remains a topic that is very much understudied.
So another aspect of patient-provider concordance is the cost of a lack of concordance. And one thing that we learned that intellectual stereotypes are one major cost. So, a study of racist beliefs that have carried on since slavery found that lower levels of education equaled higher beliefs in racist perspectives. So, although we have this belief that only white individuals with low levels of education are racist, and how would that affect a GYN experience? It would affect it in several ways. Because we don't just see our physicians. So there's people in billing and coding, there's people in appointment setting, medical assistants, and even first generation doctors. So anyone who has not received an advanced degree and hasn't been around ideas about questioning racism has the possibility to approach Black patients with these intellectual stereotypes. So Aronson, Fried, and Good in 2002 found that intelligence-based stereotypes are so pervasive that they even affect Black people. And their studies show that when Black college students internalize these stereotypes, it actually has a negative effect on their academic success. Again, according to a study of medical students, over half of the sample believed that whites had larger brains than Blacks. Blacks were significantly more fertile than whites, and that Blacks have stronger immune system. So we see all these stereotypes that medical students carry into practice will obviously have a negative impact on Black patients. To continue this along, Hefleck 2011 found that several studies of implicit and explicit bias show white Americans describe Black people in general and Black criminals in particular using animal terms, using the same kind of descriptive words you would use to describe animals, frankly. And there was also evidence that Black faces could help prime white people to jog up memories of apes. Welch and Singelman in 2011 studied this notion of an Obama effect. So their thesis was that now that we have this biracial president, race relations have improved in America, and they wanted to test that empirically. But interestingly, though, their study found the shift was minuscule. So as you see in this table here, in 1992, on a scale of 1 to 7, 7 being very intelligent, white Americans ranked Black Americans at about a 4.2. And in 2008, when they believed this Obama effect had kicked in, actually the mean score only went up by 0.2. And they also looked across groups who are traditionally expected to have big differences, Republicans versus Democrats, high school grads versus college grads. And there were the expected differences where college grads and Democrats gave Blacks a little more credit as far as intellect. But as you see, it's a very small difference. Finally, Jackson and colleagues in 2019 studied children, 5 and 6-year-old children of all races. They showed them pictures of white, Black, male, female adults and asked them to rank them as far as brilliance. They were hoping to establish that gender is the greatest predictor of brilliance, because before this study, white men always were ranked as the most brilliant. Interestingly, though, when race was brought in, there was a different outcome for Black folks. So the first two, white men and white women, were the most brilliant, but then with Black people, Black women and then Black men were the most brilliant. But either way, we see this intellect stereotype even starts at 5, where kids just simply assume white folks are more brilliant than Black ones.
So to bring us back to our study of sexual health care and gender racism, we had 2 research questions. The first one was, how do Black women experience gynecological care? And the second one, what role, if any, do their race and gender play in shaping patient-provider interactions?
Our approach was to do in-depth interviews between NCAT and UNC, and we conducted those interviews from September to December 20th. At NCAT, we did 16 interviews, and at UNC, there were 15. The interviews were comprised of 18 to 25-year-old Black American women who had received any gynecological services. This research was approved by the Institutional Review Board of the sponsoring university. Additionally, this research was funded by NC TRACS Institute, National Institute of Health, through grant award number UL1TR002489.
And now we'll share some of our findings from our in-depth interviews. Okay, so one of the questions that we will present to you today that we asked our respondents was, tell me about your experiences with sexual health care appointments. So these are the themes that emerged. One was feeling ignored. This particular respondent said, there's really not much to talk about. She would never think I had a problem. If I had a problem, she assured me that it was going to be okay and that I didn't need to take any medications. It was never serious enough, I guess I would say. Another was intelligence being insulted, and this kind of takes us right back to that intelligence stereotype. So this respondent said, 16, going up, I was like, I don't know what's going on. Of course, I'm going to ask my physician about it. It never seemed it was important enough for her to recommend I go somewhere else or any other medications or anything. I felt like it wasn't important to her. Another theme on the positive side was that some gynecologists did provide education. So one young woman said she would, instead of saying something's normal, she'd explain, well, because you're in this age range, this is normal until this point. When you get to this point, if it's still happening, then come back, which made me feel better because it's like she wanted to follow up. And here are a few more themes from that question. Another was having a doctor who was willing to assist. I felt I was more honest with her because she was willing to help me in this situation instead of dismissing it. When I talked to her, I was like, I might as well tell her everything so I can get the best results rather than hiding stuff that I had already told my primary care physician. And then finally, feeling that race and gender concordance. She was just so warm and inviting and made me feel really safe. And she was a young Black doctor herself. So I felt like I can relate to her and she made me feel extremely comfortable. Oh, sorry, finally, discomfort around the sexual nature of the visit. So that's really the only reason I was uncomfortable about it. But other than that, she made me feel comfortable. She wasn't acting like it was weird or anything. So I just felt weird because it was my first time.
One of the other questions we asked was, can you tell me about your comfort level talking to your sexual health care provider? And the first theme that emerged was familiarity with medical providers. So for this young woman, having her family in the medical field was important. So she said, so I've kind of always just been always ready to be honest about stuff because I know that it's better to be upfront and face whatever the issue is rather than hide it and then let something bigger come up. So, and I'm in the medical field myself, so I've always just been comfortable being honest with my doctors. Another important theme was the medical provider approach. One participant shared, it was really my first time being fully undressed in front of a doctor, I think. So that's really the only reason I was uncomfortable about it. But other than that, she made me feel pretty comfortable. And we saw, okay, one additional theme we saw, there was race and gender concordance. One participant said, I'm very comfortable just because I chose her. I think in general, if I didn't choose who I was going to, and it wasn't someone that looked like me, I think it would be a little more difficult for me to feel comfortable.
Dr. Parker?
So the next one is, are you completely honest with them? Why or why not? Safe space and judgment-free zone was a major theme that arose with the study participants. Because I had nothing to hide at this time, plus during that time, not that I had anything to hide from my mom either, but she always had my mom leave the room whenever she talked to me about gynecological care and stuff like that. It was honestly me and her, and I'd be honest about it. Trust became another issue in regards to patients and their visits with their doctors and whether or not they can be completely honest. I think it goes back to just the relationship. Have known each other for such a long time, I trust in her as my doctor. Vital for proper health care. I feel like all other people, they should have been the person that I'm lying about my sexual history and things like that. If I'm just asking them to help, I can't be lying to them about that. I have to go on, especially when I think sexual history is important, especially if you're trying to get help with it. Like, you shouldn't be lying about it because your answers could affect the way that they treat you. And I don't want that.
So another question that we discussed was whether their race or gender created an issue at their clinic or hospital. A few of the ideas that emerged was other sectionality identities like age. One of the participants said, I feel it was more my age that she didn't think I knew what I was talking about because I had been younger, which 17 or 18 really isn't that young to me, but perhaps to her, I was younger. Another theme was due to cultural competence. One of our participants said, like the patients that they see are people of color. So I've never felt uncomfortable. And a lot of the other people working there as well were also people of color, like Black women as well. Blackness as a barrier to care was another theme. I guess like I've noticed that with my Blackness, sometimes my issue may not be seen. Whether I come with a concern, it may seem like it's downplayed by physicians or whoever I decide to go see. It's like they're like, are you sure? It may not be that serious, but to me, I've never experienced it before. So it's pretty serious to me. But I think that's really the only issue I have with my Blackness in getting my health care. Another theme, comfort with other racial minorities. She said, I don't think so. Nothing that I've noticed really on my race or gender because my doctor, now she's an Asian woman. So I don't feel like my race or gender does anything. And finally, race and gender concordance. So our participant said, but I think because I made it apparent that I wanted a Black gynecologist, then it kind of helped me out better. She's more understanding and she makes sure I'm aware of all the different things that I can receive at campus health, but also things that if I didn't have the ability to get them at campus health, where I can get them somewhere else. So she's been willing to give me referrals and things like that. But I think in general, if I didn't have a Black gynecologist, I would not receive the same attention.
The next question that we asked is, do you feel like your Blackness has an impact on the care that you receive? And what we heard was Blackness as a barrier to care. Whenever I go to Cone Health, I feel more like a routine patient, like get in, get out versus you're one of us. Feeling race, gender concordance. I can say my comfortability is at an all-time high on my campus just because, like I said, all the nurses and doctors and physicians, they're predominantly Black. So they're in the same mindset as me for the most part. And as far as understanding my fears and being a college student and all that. Next was anxiety from historical medical racism. I'm always skeptical in medical settings of the care given to Black women because of the history. At the same time, I feel like Black women aren't given all the details when it comes to medical settings, but that's just me being skeptical. I don't think there's been any instances, like direct instances of that happening. And the last is other intersectional identities. Age. They're all pretty young. I think that makes an impact too, because think if they were older, there might be some things that were more racial bias in their practice, but I think that they've all had a pretty much understanding and respect for me as a Black woman.
So while this study was a great start to researching Black women's experience in healthcare, we still have a long way to go. Future research, Future research should include more studies of sexual and gynecological care with Black samples across class groups. More social behavior research that centers lived experiences and considers medical racism. Studies of care seeking behaviors in Black women, the impact of trust and maltreatment. Qualitative interviews of Black female medical professionals to uncover best practices for healthcare. And lastly, we should survey practitioners of all races to understand variance in treatment patterns, for example, C-sections and birth control.
Some practical applications we believe could come from more studies and from our study specifically. Physicians should be trained on ways to center culture, values, and invest in the community that they serve. So we saw previously that people didn't feel heard. They felt like their physician didn't really listen to them. And we believe that if the physician had their understood their cultures and values, then they can really, and they actually invested in the communities that they serve, that these instances would be eliminated. Also, training medical professionals on ways to create judgment-free zones. A lot of the women that we spoke to really found it valuable when they could speak freely and they didn't feel like they were being judged. So there should be specific training for medical professionals to create that environment for our women. And that leads into patient-centered experiences as well. This decreases the feeling of being ignored or having their intelligence insulted. Once the provider really focuses on the patient and what they believe is wrong and addressing those issues specifically rather than being dismissive, then we feel like there's now a judgment-free zone and women can feel comfortable in that environment. Also, what would also be very great is recruiting and training Black girls and women to pursue careers in medicine. We saw that a lot of the people that had very good experiences did have Black women physicians for their gynecologist. And in the previous slide for our future for future research, we saw that we wanted to survey more Black women on how exactly they show that care and showing their values and being able to listen and create those judgment-free zones.
So we thank everyone for listening to our presentation, and we're excited for more dialogue around this topic.
Thank you guys. Thank you all. That was a great presentation. Attendees, feel free to use that Q&A feature. But to start off, I'll start off with my own questions. I thoroughly, as a Black woman who is, of course, maturing and going through age and having to really take those I now schedule my own doctor's visits, So now I'm more interested in who I see and when I go, and having access to these conversations are extremely important. And it leads, and Dr. Wade, feel free to answer first. It leads me to the question of, it makes me think, when was I supposed to hear this conversation? Did it start from my mom? Did it start in school when we had that sex ed? Or was I supposed to first encounter it when I first went to the doctor in college? So when do you think that this conversation should start, and who should be the voice to that conversation?
Well, my instinct is I have two answers. One is your question reminds me of the talk, how when we talk about raising Black boys, how we prepare them for police encounters. And when we raise Black girls, we have to prepare them for certain encounters as well, the gynecologist being one of them. And, I would say as early as possible, because we don't want them to have horror stories that open their dialogue that lead us to say, oh, by the way, you should go to a Black woman. So I would say as early as possible. And then the second thing I'm thinking about is the intelligence stereotype, because that really stood out to me. And recently I had a young Black girl talk to me about her dream to diversify Black history curriculum. And she said, we have all these Black people who graduate without understanding Black greatness or Black struggle, and it's not fair to them. And I said, hold tight. We also have all these white people graduating with no information on Black greatness and Black struggle. And so we need to talk about diversifying curriculum early on to really get to the root cause, to really make it okay to have cross-racial relations at the doctor because these people of two different races have unpacked their biases and learned history in a real way so that we can have comfortable experiences.
One of the things I would like to add to that particular question is that it is important to have that conversation early on, but it's also important for parents to be comfortable in having that conversation. And I think a lot of times parents are not comfortable in having that conversation, and they avoid or tiptoe around conversations when it comes to young women around their sex and sexuality and what to expect when they go to their gynecological visits.
Thank you to the both of you for giving us those answers. I appreciate it. In the QA, we actually have Pat Levinson had a question. So she says, there is a huge history of Blacks not getting anesthesia during surgery in the 1800s into the 1900s. Did you do any research on Blacks not feeling pain or Blacks not feeling pain the way whites do? If you guys encountered that research, anyone feel free to unmute and answer.
I'll go ahead and say, for this particular study, we have not focused on this issue directly, but the literature that we reviewed does acknowledge that because of instances like that, right, especially the pain issue that's a lot more recent, where we have a lot of documentation from studies that, you know, Black people, when they're in pain and ask for pain, the pain is minimized, so there's a delay in getting medication, and compared to whites who are not asking for medication and they are offered because the assumption is that they're in pain. So when we think about all that, we think about that the mistrust that leaves, you know, for for Black women, for Black people seeking medical care, especially Black women and their gynecological health. So I do see the connection with those discriminatory stories and how they might be impacting Black women's willingness to seek help, you know, to do all those preventative things so that they can have better gynecological health outcomes.
I see you were going to say something, Q. Before you do, I just want to add, we are actually two-part data collection process. So our in-depth interviews did not touch on pain, but in a month, we're going to do focus groups across both campuses. And we actually plan to talk about Tuskegee, talk about medical racism, and sort of get feedback from the participants on how that affects their willingness or reluctance to go to gynecology appointment.
Mm-hmm. And more specifically, we are probably going to touch on James Sims, who was noted as the father of psychology. And he did perform those surgeries on Black women without any anesthesia. And he really pushed the idea that Black women feel pain differently. And this idea we see is constantly coming up. 40% of first year and second year medical students, there was a study that they felt like Black people's skin was thicker than white people's, so they could feel pain differently. And also in a study by Gallagher in 2012, they said Black and African American patients, they received pain medication 22% less than actually their white counterparts. So we see this theme consistently coming up, and we are doing a more in-depth study on it.
Thank you for that. The other question we have, and again, is just open-ended. Whoever would like to jump in, feel free. And excuse my puppy in the background if you hear him. I have seen and heard, this is from Martha. She said, I have seen and heard different discriminatory stories about maternal mortality rate as it relates to Black women in the healthcare system in the United States. What do you think Black women should do to tackle this issue?
I have not had any kids, but I have friends who have kids. And I think being afraid to say I want a different doctor is where it starts. Just being open and honest, you know, in a place in Greensboro, for example, you can do that. But if you're in a rural setting where you only have one, you know, gynecologist in that area, that's, you know, another barrier to your care. We're very privileged to say, you know, I want to go to a different hospital or to a different physician, but people who don't have that option, I'm not sure what they can do. But again, somewhere like Greensboro, you can say, you know, I'm not happy with my care here, and you can find another OBGYN or another midwife. But again, in those rural areas, that is a very complicated question that I'm not sure we have the answer for yet.
And I definitely think that it's like an institutional issue, because even we see people like Serena Williams who have all of this, who has all of these resources, all of these accesses, and yet she still had to get up out of her bed and demand her nurses to run tests on what she felt like was wrong. So it's not access. It's not like the it's not Black women being less intelligent, not having health care, not having the means to pay for it. It's really institutional that we need, where we need to start building from the ground up and address these issues.
And I agree with what has been said. And a part of that will start back in terms of how do we educate physicians, and how do we reframe the narratives that they've been given, and help them to understand our realities. And many of you that are in the audience, you may be students, and you have an opportunity to help reframe this narrative. You have an opportunity to be a part of medical schools and decision-making and policies and education. So I think as a collective, we could choose what areas are our strength and tackle that. My way, I've been trained as a social worker, and I train students to be social workers. So a part of that is working with their social workers to help them to advocate for themselves. And that's what the students have really talked about, is really advocating for yourself. And if you don't feel comfortable with something, it's okay to say that you don't feel comfortable. And it's also okay to ask for more information. Sometimes physicians talk with patients and not in a jargon that patients can always understand.
Thank you, Ms. Parker. That's kind of a great segue, because I was just going to mention, because you guys are talking about so many like levels of space, right? So there's just like the idea that any Black woman in any building, and that there should be something done in those spaces so that we always feel comfortable. But unfortunately, that doesn't always happen. And sometimes, like Brianna mentioned, there is one OBGYN office and the closest, and that's the only way you can go to. So my question is, what are some of those like small things that you, for one, what is something that is those things that are unacceptable? So if you are a Black woman and this is happening, you don't accept that. And then the second thing is, so what should I do? So now that imagine, I could only imagine a woman who maybe isn't tapped into her voice yet. How does she handle that, really large or unusual jargon and those uncomfortable spaces? And what does she do to get out of that or get the best treatment in that space?
I want to talk about alternative health options, like Q brought up, midwives, doulas also. In the Black community, we are like very underrepresented among doulas, and very underrepresented among people who utilize those services. So that's a great first step, because they are your liaison. I might have a PhD in sociology, but I don't have an MD in gynecology. So I'm not able to speak the jargon myself. There's only a small segment of the population who can. So there's so many professionals. There's community health workers. I'm from Ohio. We had a Healthy Start program. I'm not sure what it's called in North Carolina, but there's federal programs like that could serve to be your voice. So finding whatever is at your economic availability to have someone to kind of go through this pregnancy with you, because this is a long process and it's the most important process that women will go through, frankly. So I think getting help is a great first step.
Alrighty. And and you guys mentioned a little bit about your methods to your research. If you want to, anyone want to speak a little bit more about why you specifically chose those methods as opposed to others?
So we chose to do individual interviews at this time, based on the questionnaire that we developed. And this allowed us to go in and ask more personal questions that we would not ask in a focus group setting, for example. Some of the data that we're presenting to you now would not be appropriate to ask these type of questions in a larger group. And then also this is being used to kind of help build up the questionnaire that we're going to use for the focus groups with that as well. And it's just an opportunity to also establish a relationship with women and give them a space to be able to speak openly and freely in a non-judgmental zone.
And then also, as opposed to using quantitative data, this gives us rich data, the in-depth interviews. I'm on several other medical racism studies, and we keep coming to the same conclusion. These established scales don't work. So instead of us using a quantitative scale to ask Black women why they don't go to the doctor and finding out none of those 5 reasons apply, the best practice is to let the Black women speak for themselves. Frederick, did you want to add something?
I was just going to add the significance for us using 2 Black women from 2 different spaces, predominantly Black space and one in a predominantly white space and institution. That really allowed us to start thinking about the differences in access and socioeconomic status and other things that might be embedded within that. So we're looking forward to hearing more from the women in those focus groups, so that as we think about creating better instruments, right, that we'll really capture the experiences both from the women who have access and have more supportive Black women around them, and for women who might not have that at the college level, and ultimately to take this outside of the college level, because we know, the rubber meets the road really when we take it out into our communities.
Thank you. And you mentioned, Ms. Wade, that, or Dr. Wade, that it's similar to the talk. So, so having these discussions, and I always hear about the talk, right? So I hear about the talk on like Grownish and all these, or Blackish, or whatever the case may be. I never really hear about that as in response to Black women. So that kind of makes me wonder if we're having another women's wave without Black women being included. And I'm wondering your thoughts about that, and how movements like Black Lives Matter may or may not include Black women. And everyone feel free to answer.
Yeah, so I think parents struggle with wanting to let their children stay innocent. I know I do. And I have some pretty woke kids. That's the cost of having a sociologist mom. But it's like, you don't want them to go out in the world and just think the worst, The fact that I have to say, here's my 5-year-old. The fact that you have to say, when you go to the doctor, seek out a Black woman, that's traumatizing to children, because now they have to know, well, why? Why can't I get good care from a white person? So I think parents are scared of, once you open that can of worms, there's no going back. But sadly, until we reframe curriculums and really tackle racism, we are going to have these talks. You have to behave around the police. You have to find a culturally competent provider when you go to the doctor, because otherwise your level of care will not be the same.
And I think, just to piggyback off what she said, in addition to that, we are a nation steeped in patriarchy. And some of these conversations don't happen because of that. The talk doesn't happen because of that. And it's only when we have conversations secretly with our moms or grandmothers, or we look up on it on Grownish. It's not something that's taught to us, because we need to be good and we need to be chaste and we need to keep our private parts private. And we're not allowed to talk to them with the same talk about these things and with the same freedom as everyone else in the room does most of the time. So I think that's another factor that definitely needs to be waded through in order to really be honest about the talk.
And I also think that we can create spaces to have these conversations about the talk. I kind of think about my role in my family and in my world. I'm not a mother, but I'm an auntie. I'm a biological auntie and an auntie of other people as well. So how do I create this space when we can talk about sex and sexuality, but also be able to kind of talk about how do we take care of our bodies and ourselves? And I don't know if people in the room are having those conversations amongst your peers, but we can begin to kind of have those conversations, invite people like those of us on the panel to kind of help guide some discussion around that. This is real important. And this is definitely a movement, Ms. Carter, that we can definitely start about being open about our experiences. And then how do we navigate these experiences? A side note is many of the women in the study didn't know what to expect the first time they went in for their pap smear. And there was this fear around what to expect around the pap smear. And there was a focus placed on the pain that may be associated with that. So how do we navigate this in a different way? And it's going to take all of us to do that.
One more point about that was also in the interviews, women talked a lot about their religious component and talking about sex and how, you know, it was a no-no in their house. It just kind of, they may have learned it from school or from peers, or maybe they kind of stumbled upon porn at school, but their parents never talked about it because it was such a taboo thing. And I think that's starting to somewhat be not such a taboo anymore. As I know I'm getting older and having younger cousins, but it's still very much a taboo in the South, especially. We live in the Bible Belt. We cannot forget that. So just having those really open conversations, not just about, you know, going to the gynecologist, but about sexual health in general, I think is a great start.
And I want to say one thing, because we didn't directly tackle your Black Lives Matter question before we move on, because I'm a medical sociologist, so I'm a very passionate advocate when it comes to talking about health disparities. And I think in this particular thing, it's less gender, but more genre, because it's really like sexy to talk about police brutality. Now, of course, we don't talk about women enough. We don't have justice for Breonna Taylor, but at least we know the name, we know Sandra Bland. When it comes to medical racism, for some reason, it's not getting the media attention, because Black men have the same health as men in Bangladesh. Black women have obesity rates like in the top 3 highest countries in the planet. So we have clear data that medical racism is a crisis. We can all say Tuskegee happened. You know, we know about the C-section trials, but for some reason, I don't know if it's because police brutality is on camera, so that's more shocking and viral. But I think in general, we don't do a good job talking about medical racism.
And I agree. In my own personal experiences, I have not had children personally, but I am a sister and a friend, and I've, in all different ways in which I am woman, I've heard from people that there's been a situation like my aunts have miscarried and my friends have miscarried and things like that, for what, of course, not as a medical professional, but things that I feel and have heard are remediable. You know, this should not have been the, you know, the outcome. So I hear everything that you all are saying, and I understand it on another level because it is so personal to me. But how do we explain? I find myself so very often, and until this whole President Trump social media age, racism didn't exist, right? It didn't exist until 2 years ago, apparently. So I almost feel that once a Black woman says, my doctor doesn't listen to me, you know, the doctor that's smart and rich, and sometimes a white male, she may not be believed. So how does she have this conversation on a regular basis with her friends or with people who don't look like her? What are the ways in which that someone can communicate this thing that's happening in the Black community with someone who may not be in it?
I think it takes a bit of courage and a bit of just very plain speech, because a lot of times we look for ways to placate and avoid hurting the feelings of those who need to hear the truth. And I think just on the front end, just a little bit of courage. I'm not saying go all out and just start, you know, being ridiculous to get your point across, but just a tiny bit of courage and a little bit of agency and advocacy for the issue at hand.
One of the things that I would like to add, I see myself as a partner in my healthcare. And my doctor cannot tell me everything that's going on with me without talking to me and including me. So I make that very clear when I go into my appointments. And I have great relationships with my physicians because of that. And I've left some physicians because I was not included in my healthcare. I'm not just a number. I may be a Black woman who fits into a certain category of statistics, but I am an individual. So just being honest, straightforward, just like Ms. Wilson said, has been an avenue that I've taken. And I have also used as I care for my mother and her physicians. I felt like she was not being listened to by one of her physicians, and she knows no longer with that physician. Her voice matters.
In case maybe someone here doesn't know, hearing this kind of changed me and gave me hope. Like the root of what we know today as intimate partner violence or domestic violence, you know, it took women telling their story, because up to a certain point, women were just getting beat. They were just simply getting beat. And nobody wanted to talk about it. And nobody felt like, you know, their husband was wrong. This is just how life is. He comes home, he beats me. And it took a few women telling a few women, telling a few women. And this is before Twitter, you know, Instagram, whatever. But in order to have an aha moment like police brutality, we need to say, hey, this is not, what do they like to call it? A lone wolf. It's not a lone wolf. This is a pattern. So if every woman here could just have the audacity to tell somebody who could then tell somebody who will then be like, oh, wow, your doctor was racist. Mine too. Your doctor made you feel stupid. Mine too. That's how we start a broad conversation, is just having the audacity to just get it started.
I'm interested to finish up to hear what you have to say, Kwani, about just this idea of bringing this conversation mainstream and letting people know that there's a problem that Black women have.
Definitely bringing it mainstream, just like how the Black Lives Matter movement was brought mainstream via social media, via the TV, so that even all ages can really be involved in that conversation. But I really think that social media is going to be a huge aspect in getting information out so that people understand, as Dr. Wade had said, that this happens to me too. Like I feel dumb. I don't feel listened to at the doctor's office as well. And really listening to Black women, I think that's going to be the main thing, is listening to Black women and giving Black women a voice, giving Black women a stool to step on so that we can speak about our experiences, so then it is addressed.
Thank you all. I would like to thank you all for all of our amazing panelists for sharing such great and needed information with our communities, and being, you know, having the audacity to say it yourselves, and being an inspiration to someone like me to, you know, use their voice. But yeah, so the CACE continues today. There's programs, our panel discussions every hour until, I believe, 7 or until 6 is the last one starts. So you guys enjoy the rest of CACE. And again, thank you, panelists. Thank you.
Thank you for the opportunity.
Absolutely.
Thank you, everyone.
Thank you.